Good morning, and welcome to the Coy W. Waller Distinguished Lecture for 2018. My name is Noel Wilkin, and it is my privilege and honor to serve as Provost and Executive Vice Chancellor for Academic Affairs. I'm also proud to hold a faculty appointment in the School of Pharmacy, specifically the Department of Pharmacy Administration. I bring greetings from the Division of Academic Affairs here at the University of Mississippi. I also bring greetings on behalf of Chancellor Vitter, who is in the audience with us today, and from the entire university administration. The University of Mississippi is a historical place, and it's easy to think about the university as the spot, the place, and the buildings because they endure from year to year. Yet none of those things are as important as the people who are using those enduring places. The students, the faculty, the staff, the alumni, and what happens here is the most important thing. In today's world, it's easy to get distracted from what we do as an institution, for our attention to be drawn away from the role that we play in society and the role that society plays. Stop and think about it for a moment. Why do universities exist? What is our role in society? While we are a complex organization with many different individuals involved, our reason for existence is quite simple. It's to discover and create new knowledge and transfer that knowledge to others to enrich the lives and improve the lives of people. We unlock creativities in ways that fuel perspectives, discovery, and potential. And there are many amazing ways in which we as an institution and our people do this. One of those ways is through named lectures. By naming the lecture, we acknowledge the creativity and the meaningful contributions made by Dr. Waller. By bringing in a national expert, we advance our understanding of the meaningful work that Dr. Mullins and Mr. Patterson are doing. And we don't do this to convince ourselves to do what he's doing or what they are doing. We do this to expand our understanding, to showcase their approach to meaningful work, and help each of us to appreciate the breadth of opportunities to improve health and make a difference in the lives of people. This welcome is particularly meaningful to me because Dr. Mullins is a faculty member at my alma mater. He joined the faculty at Maryland just before I moved to Ole Miss. It is my great honor to welcome him to our fine institution, and it is my privilege to welcome you to this outstanding event. As I turn the microphone over to Dean Allen, please help me thank Dr. John Bentley and David Dean Allen for planning and hosting today's lecture.
Good morning. Thank you very much, Noel. I very much appreciate your presence today as we honor the career of Dr. Coy W. Waller. I'd like to thank the Department of Pharmacy Administration for co-hosting this event, as well as Dr. Daniel Mullins for serving as the 2018 lecturer, and Mr. Dawuan Paterson for joining him today. You'll hear more about them in a few moments. We have honored Dr. Coy W. Waller in this lecture series since 2004, and it is my great honor each year to tell you a little bit about him. Dr. Waller was an amazing man with an outstanding legacy in natural products research. He was born in 1914 in North Carolina. He received his bachelor's degree in pharmacy from the University of North Carolina, his master's in microanalytical chemistry from the University of Buffalo, and his doctorate in pharmaceutical chemistry from the University of Minnesota. He began his 11-year tenure at the University of Mississippi in 1968 as the Associate Director of the Research Institute for Pharmaceutical Sciences and became its first full-time director 2 years later. He advanced the Institute in innumerable ways. His focus on natural products as a source of new pharmaceuticals laid the foundation for the creation of our own National Center for Natural Products Research, the first of the Institute's now 4 centers and an internationally renowned institute in of itself. Before retiring in 1979, Dr. Waller conducted research on poison ivy and the use of cannabinoids to treat glaucoma. He also helped edit bibliographies on marijuana and cocaine. Over the course of his career, Dr. Waller authored more than 50 patents, which were issued in more than 150 countries. He was passionate about inspiring students and young colleagues to pursue natural products research and to realize their potential to develop new pharmaceutical products. In 1993, the university honored him by dedicating the Coy W. Waller Laboratory Complex, a natural products laboratory that houses our marijuana garden, medicinal plant garden, and greenhouses. Dr. Waller was one of the most accomplished scientists of his time. We are incredibly grateful for his contributions to our school, our nation, and the world. When Dr. Waller passed on April 24, 1998, the school pharmacy lost an inspirational leader, and the world lost a research pioneer. We are honored to have some of Dr. Waller's family with us today. Ms. Liz Thomas, Ms. Deb Carnathan, Mr. Dave Waller, and Mr. and Mrs. Jim and Beatrice Waller. Would Dr. Waller's family please stand and allow us to recognize you? We are delighted to have you with us here today, and we're grateful for all that you do for the school and for the university, and great contributions to the School of Pharmacy. I would now like to welcome Dr. John Bentley, Chair of the Department of Pharmacy Administration, to the podium. He will introduce Dr. Daniel Mullins as our 2018 Distinguished Lecturer. John?
Thank you, David. Good morning. Thank you. Good morning. On behalf of the Department of Pharmacy Administration, the faculty, the staff, and the graduate students, we are delighted to have you with us today for our 2018 Coy W. Waller Distinguished Lecture. After the lecture, we will welcome any questions from the audience. Students will be available to provide you with a microphone during that time. It is now my privilege and honor to introduce the 2018 Coy Waller Distinguished Lecturer, Dr. C. Daniel Mullins. Dr. Mullins is a professor and chair of Pharmaceutical Health Services Research Department at the University of Maryland School of Pharmacy. He received his BS in economics from MIT and his PhD in economics from Duke University. Dr. Mullins is the director of the University of Maryland Patient-Centered Involvement in Evaluating Effectiveness of Treatment program, which is an infrastructure that supports patient-centered outcomes research and training. He also serves as the Associate Director of the Center on Drugs and Public Policy at the University of Maryland School of Pharmacy. He has served as a member of review panels with the Agency for Healthcare Research and Quality, for the National Cancer Institute, and has chaired study sections at the Patient-Centered Outcomes Research Institute, or PCORI. Dr. Mullins is co-editor-in-chief of the Pharmacoeconomics Journal Value in Health, and author or co-author of more than 200 peer-reviewed publications. Among his professional awards are an Outstanding Service Award from the Drug Information Association, the Marilyn Dix Smith Leadership Award from the International Society of Pharmacoeconomics and Outcomes Research, or ISPOR, and the Dr. Daniel D. Savage Memorial Science Award from the Association of Black Cardiologists. The University of Maryland has honored him a number of ways, including as the Dr. Patricia Sokolov Outstanding Mentor Award, the Wilson H. Elkins Professorship, and the 2014 Research of the Year, and finally as the 2017 Martin Luther King Jr. Faculty Diversity Award. Dr. Mullins is bringing with him a guest today, Mr. Dawuan Paterson. Mr. Patterson is a business person, a public servant, and a community organizer. He received both his bachelor's in psychology and his MPA in public policy from Bowie State University. He's the executive director of the community development consulting firm, the Be More Group. Mr. Patterson is also a social impact consultant for the City of Baltimore, where he uses strategic planning and economic development to highlight and solve challenges in the community. His professional interests include societal issues in education, public policy, economic empowerment, and ethnic and racial studies. He has spearheaded and lent his expertise to programs that promote education and economic empowerment in underserved communities. To this end, he has held voter registration drives, toy drives, workforce development forums, job recruitment seminars, art exhibits, and more. Motivated by his own life experience, he has consulted with various stakeholders from Baltimore City Hall to Capitol Hill on developing workable, tangible solutions for socioeconomic quality and criminal justice reform. He works diligently to be a voice for the unheard and the unnoticed. The Department of Pharmacy Administration is thrilled to have Daniel and DeJuan with us today as they present a talk entitled Patient-Centered Discovery. Please join me in welcoming Dr. Daniel Mullins and Mr. Dawuan Paterson.
Thanks very much.
Good morning. As was mentioned, I started the Patient-Centered Involvement in evaluating the effectiveness of treatment, or PATIENCE program, at the University of Maryland about 5 years ago. The purpose is to transform the way that research is done. Our philosophy is that if we really want to make patients and communities healthier, we need to change our approach to scientific discovery. We need to learn to listen. We need to develop our research through the lens of patients. We need to develop our research through the lens of community leaders and community advocates and community clinicians. We need to make scientific discovery more patient-centered. The PATIENCE program has a vision that patients and stakeholders are heard, inspired, and empowered to co-develop patient-centered outcomes research. Please join me now in listening to Dawuan Paterson's story.
The night I became them to the police. It was a summer night going into 2005, my senior year of high school. Just like any other night, I was just leaving a long day of work from my summer job in East Baltimore. I stopped past a friend's house. I picked up one of the neighborhood bikes, and I asked one of my homegirls, can I use her phone, listen to the ringtones? And started making my way to my aunt's house. And while on the bike, I was listening to ringtones and just enjoying myself, reciting the lyrics. And then I told myself, pay attention to your surroundings, so I put my phone down. I look up, and there's a gunman at my side. I knew that I had to give him what I had. So I gave him everything I had, and I looked back down, and I said, it's not mine. It's not my phone. He said, I don't care. Give me that too. I gave it to him, and that wasn't enough. So he told me, turn around. And that's when he pulled the trigger. My body went into shock and those things like that. And just with an ounce of strength left inside my body and a little bit of vision I had from this one eye, and I pick up and I'm wondering, looking for some help, saying someone can help me. And I get the strength to open up my eye just a little bit. And this time, I'm staring down the barrel of another gun. I was staring down the barrel of the police. And I can hear them yelling, "Get the f*** on the ground." I can hear my family and friends screaming, trying to defend me and speak for me. Because here I am with a hole in my head, leaking. "What's your name? Get the f*** on the ground." And even inside my moment of being a victim, I'm criminalized. For such a long time, I carried this stigma that I would be judged because I was a victim of gun violence. When I go back inside those neighborhoods, they call me a walking angel. I actually still have bullet fragments inside my head. My story is not just my story. My story represents a lot of people who feel disempowered, a lot of people who feel hopeless. We talk about, oh, it's black on black crime and police brutality is a separate issue. We talk about community violence. And for us to address community violence, we have to build community. To eliminate this us versus them warrior mentality, I knew that I had to do something for the individuals that was not only a victim in front of the gun, but behind the gun. We're more than just an unarmed black man, all these negative labels that we tend to get.
Can we train the police with mental health professionals?
I am a community advocate. I am a leader of my family. I'm fortunate enough to survive and tell you, I am Dawuan Paterson.
Ladies and gentlemen, please join me in giving an Ole Miss welcome to Mr. Dawuan Paterson.
Good afternoon, everyone.
Good afternoon.
I thrive off energy, so I need some more energy from everyone. Good afternoon, everyone.
Good afternoon.
Thank you. Again, my name is Dawuan Paterson. You heard a little bit about my story, how it influenced where I am today. And here you have a little bit about the talking points of my trajectory, what brought me to the place I am today. From community organizing, where you have me being involved in youth development and educational interventions across Baltimore. So that was a starting point where I learned about the individual factors that may contribute to youth violence and aggression. But as I matriculated through that professional experience and personal experience, I learned that there were institutional and system factors that contribute to such illness, environmental trauma, and these different things like that. So I had to take it a step further to actually understand about policies and systems. And from that work, I went on to do advocacy work in higher education. Higher education, I learned that given the access to higher education, it could disrupt some of the deviant behaviors, some of the things that contribute to youth violence and aggression. That led to my public service of understanding about criminal justice reform. And working on the Hill to the local government, we learned that if we was to increase different types of public recommendations where communities are a part of the decision-making process, we can actually render some of the bad police and community interaction. As a result of that work, I helped to influence policies that transform Baltimore local police recruitment and residency rate from less than 21% to nearly 40%. So you always know that if you were to bring the stakeholders inside of decision-making process, we can begin to have impactful solutions that has transformational outcomes coming out of it. That later led to my work with the Mayor's Office of External Affairs, and where we could develop youth initiatives that invested inside youth for entrepreneurship, education, and things of that nature, because we learned that not only social justice matters, but economical justice is really important. And that brings me to the next level of my work on patient-centered research. We tend to forget about healthcare playing an immediate role inside of our life, even though we may think it's something that's relatively simple. However, it's not something that's talked about on the forefront. When you're talking about trauma, the level of psychiatric impacts of going through traumatic experiences from childhood to adulthood, we don't think about how can we really address some of those needs on the onset, at the beginning phase of that. So when I was introduced to Dr. Mullins, and we were talking a little bit more about that, we was thinking about how can we develop authentic relationships that have the community at the beginning of the process, from the decision making, the actual clinical trials, the research itself, the evaluation. So at every level that you could think about, you will have the patient in mind and at the table, and we will see that there is importance of having the patient seen as partners opposed to just subjects. So that was really important for me in knowing the health-related outcomes. And we talk about trauma from the work, and that was something that was dear to me. And knowing that the immediate community is surrounded in Baltimore, gun violence is something really important. So that led to the onset of a relationship with me and Dr. Mullins in the patients program to actually to understand, examine the impact of gun violence and the costs of it. So how can we drive about policy and research opportunities that really bring about that change that led to many other opportunities where we can see how we can incorporate the patients in the pharmaceutical world as well.
Like Dawuan, I too had a journey. My journey started with engagement, but engagement of insurance companies and payers. I was an economist, and what I had to contribute to the profession of pharmacy was an understanding of whether medicines were worth paying for. How much is too much? And what are we willing to pay to save a life? So my original engagement was engaging payers and asking them what information they needed so that they could decide what drugs to cover. I did a lot of nights on the computer crunching data. And over time, as I was looking at value, I began to remember that these data points are people. And I was fortunate that pharmacists and physicians and nurses and social workers brought me into their clinics. And I got to meet some data points. And that has made all the difference. I've learned that I can talk to a patient, and that by talking, I can understand how to transform my scientific discovery to be more patient-centered. Having walked that journey and having had the good fortune to work with people like DeJuan and other leaders, I also came to understand the responsibility that comes when you understand what someone's been through and they share their story. And then it's up to you to have an impact. And so I started the Patients program out of my journey. I started the Patients program because patients have questions. And our research hasn't really answered the questions that patients have. Part of the reasons that patients don't trust research is that they don't understand it. They don't feel that they're getting their questions answered. And so we decided that we should answer the questions that patients have. We also felt that, as Dawuan said, that systems haven't done a good job of answering patients' questions. And so we want to transform the way that learning healthcare systems learn by engaging patients. So we started the Patients program. And the first thing we do is listen. What we recognize is that we need patient engagement at every step. What does that look like, Dawuan?
Well, as previously mentioned, there is really a strong importance of having patients at every step. I use an example where we have another community partner, Gail. Gail has a history of a chronic disease, and excuse me, she's not here, but it's a public story she shared. She is a person that suffered from HIV/AIDS disease, and she tells a story about how she was contacted and recruited to do a photo shoot for a pharmaceutical drug for a person with HIV and AIDS. And at the moment she was doing that photo shoot, she realized the message that they were sending wasn't sensitive, aware of the patient at that time. So she had to re-ramp and educate the company on how to authentically share the message where it does not come off in a very condescending way. So that would impact the level of patients in there. So as a result of that incident, along with myself, Dr. Mullins, and Gail, we went to a pharmaceutical company and led a conversation and discussion of how we can engage patients at the onset, not at the end result, where you see patients actually driving the marketing campaigns of how authentically to engage and send the right communication and message. Because if you send the right message, then you will have more patients and community advocates speaking for the drug or the product that you have here, and that would, and the end, increase your outcomes, because now you have people who are more receptive of the work that you're doing, and it builds a level of trust and respect for the community members. Because if you don't show a level of trust or respect, then you're more likely won't get the level of rapport that you need, and it impacts the research, the outcomes, and the deliverables in which you are destined to create. And so you don't want to create a helicopter approach when we're talking about research. Oftentimes vulnerable communities have this level of medical mistrust because oftentimes researchers come inside the neighborhoods in their community, they drop in, extract what it is that they want and need, and they fly right out. So you have to build a mutual beneficial relationship where it's not transactional in nature, more so transformational. So when you have these level of key principles inside of the patient-centered research, you're allowed to build trust, respect from both parties.
In my journey to patient-centered discovery, I'm still a researcher. And so I published my only Journal of the American Medical Association, JAMA publication. And it outlines the 10 steps that occur in research. And it describes how it is that we could engage patients at every one of those 10 steps. As DeJuan said, not just when you're done and you're trying to figure out how you can sell your results to patients. I'm very proud of that 10-step, and we use that 10-step in every research process that we use, and we will not support researchers who don't buy into the idea of engaging patients, community leaders, and other stakeholders at every step. But we listen. And one of the things that we learned is that 10 steps to community members is a lot and confusing. And so we took our first 3 steps, which are about what is it that we might want to answer, and how do we let patients give us some questions, and how do we prioritize, and how do we frame them? And that was about planning, and that we wanted to make sure that we invited patients and community clinicians and stakeholders to be engaged in the planning process so that we would design our research to be more meaningful. And then we had the series of steps where we were looking at conceptual frameworks, and we were looking at analytic methods and data collection processes. And one of the community members said, "Aren't you just talking about doing it?" And so our 4 middle steps are about doing it. And then at the end, we're talking about implementation science and translation and dissemination. And in a research context, we would say we want to bring the results of our research to the community. And what we heard was a lot of patients don't want research results. They have medical problems and they want you to deliver solutions. So our last 3 steps are about delivering solutions to problems that real people face. And that's what happens in the transformation process when you listen to patients. And because of the neighborhood surrounding our campus, we want to make sure that every patient knows that their voice matters. That the diversity of Baltimore, of Mississippi, of the world matters. And so we try to address the questions that patients have. We try to make sure that when that gets translated into healthcare delivery, that the patient's questions are being addressed. And that the only way to do that is to co-develop both our research and are learning healthcare system models with patients and stakeholders.
When we think about some of the hard-to-reach populations, we come with preconceived notions and bias that begin to limit how we engage people. Later on in the slide, there's a moment where we talk about being monolithic. Oftentimes, we see people as there's like a cookie cutter lens when we see people. I use this analogy when we're talking about everybody has a last name, correct? Correct? Yes, it's the last name. So my last name is Patterson. So you go inside the Patterson household, everybody has that last name, Patterson, but my children, I don't have any children, hypothetically speaking, but you think about your children, they share your last name, but your children's upbringing is a little bit different than yourselves, correct? But if somebody comes from the outside and they begin to inflict their bias of the understanding what the Patterson brand is, they leave out the uniqueness of the individual. So they make the bias that, hey, just because I was a male and I'm a Patterson, that I can reach the whole Patterson family, in which I reach Dawuan Paterson, the father. But no, you have to understand that each one of the Pattersons have a unique life experience, and there's a different way to engage them. Why? Because they had different outcomes, different times, but however, they had common practices, principles, and bloodline and stuff like that. So you would have these different ways to collectively group people, but you need to understand that there's different ways to reach them. So when we talk about hard to reach populations in the Baltimore community, you may have non-traditional leaders and partners, stakeholders to help you to connect with those people. And in Baltimore, we have another community partner, is Dr. Lance. He's a pastor. And many people say, why is it that you see a church as one of your partners? Because inside the community, the church has the trust of the community. They're seen as the moral authority in leadership, so I would trust you. So when we talk about, in a later slide, what Dr. Daniels will talk about a moment where we had to build authentic relationships with the church, and he would tell you, okay, this is how we do it. I don't want to jump ahead on that.
So to summarize, if we made research questions more meaningful, patients would understand the question. And if they understood the question, they might want to know the answer. And that answer would be more meaningful. But we need to make sure that that answer is meaningful for the diversity of patients. And so we celebrate diversity. And our partners include some very diverse partners. They do include our own medical system. They also include a safety net hospital called Bon Secours in our region, which services many neighborhoods of West Baltimore that otherwise wouldn't have a hospital. We have Mount Lebanon Baptist Church. We have the Association of Black Cardiologists. We have Patients Like Me that was started. Because when you or a loved one is diagnosed and you don't know anybody else with that disease, it's really helpful to be able to talk to a patient like me. And we also recently had the Indiana University School of Nursing petition and get voted in to become an official partner. I also listened to the greats in research, and clearly Dr. Coy W. was one of those. He was an individual who saw the need to start a research institute. And so he joined the Mississippi and he started the Research Institute of Pharmaceutical Sciences. And when I looked up about this wonderful individual, I saw that he recognized that in addition to himself, that he needed to hire a bunch of really talented individuals, a number of scientists to devote all of their creative energies to pharmaceutical research and development. And so I turned to people like that, and I think, wow, I want to hire some people who have creative energies. I want to hire some really smart people. I want to build something like that research institute. And I want to find people who have creative energies and work with them. And so both within the university and outside the university, I look for people with creative energies to work with. And sometimes they ask us to return the favor. Take a look at this and tell me if you know where this is. Patience Program t-shirts in case you didn't recognize.
Ooh, girl, you must be tired, 'cause you've been running through my mind all day. Come on, baby, let your mind in, and we can do whatever you may need.
So where is
Girl, you must be tired, 'cause you've been running
And how many of you wanted to get up and dance? Where is this?
Yeah, girl, you must be.
In the Target parking lot. Why were we in the Patient's Target parking lot? Or, sorry, the Target parking lot. Because it was National Night Out. And Pastor Lance, Dr. Frank Lance, told me that the Patience Program needed to be at National Night Out in the Target's parking lot. Do you recognize that? Do you recognize that? That's my city. And that's the way the news presented my city. That is a pharmacy. That pharmacy is reopened and doing well. That is the Target parking lot in 2015. And what I don't like is that that's the way most of you think of my city. But you saw us fewer than 6 months later at National Night Out in that parking lot. And that wasn't national news, but that was a lot of fun. And so what do people need to understand about what happened in April of 2015 in our city, Dawuan?
Two things that happened with the video and the before and after with Montgomery Mall, the pharmacy. If we were to go back a slide when we talk about where are we right now, you see a CVS pharmacy being burnt right now. That's something that the media portrayed and constantly show you. But one thing that they did not show you or tell you is just about a half a block, a few doors down, there's a neighborhood pharmacy left untouched. And why is that significant? Because if you do not go into the neighborhood, meeting people where they are, you won't learn about the true narrative of what is happening inside the community. You won't understand the language in which they speak. So you miss out on really important facts. And when the Patience Program went to the National Night Out, Dr. Lance was giving the Patience Program director, Dr. Mullins, a test. You want to establish rapport and respect with me. I want to see you have the right integrity to meet my community where they are. Are you willing to go beyond your campus, your comfort zone, to really learn and engage the people where they are, learn the language, build the respect, be able to touch and understand people from their vantage point. And that is really important because now I'm able to trust you, respect you, because I can touch you. There's something about engagement where we are so accustomed to high technology. And social media has helped to perpetuate that. We often forget about the high touch. being able to touch and interact with people is a really important factor that with today's technology we tend to forget about. So when the Patience program took the initiative to go inside Montgomery National Night Out and interact, understand and submerge themselves in the culture, they had a new level of respect for each other. And now the Patience program know that, hey, if we really want to connect with people and bring people inside some of our clinical trials and research and understanding, now we're able to reach people where they are. We know where to go at. We see that these are key points and places where we can really see that and engage people at a really authentic level and have a level of respect and understanding.
Hey, Dawuan, I think some of these pharmacists out there, they don't see the connection. So I'm going to skip a few slides.
Okay.
And we're going to talk about drugs. And we're going to make the connection. Dawuan's a survivor. Every day our trauma center has survivors. Some of them have had an automobile accident. Some of them have fallen down the stairs and broken their hips. But they're all survivors of trauma. And so one of the things that we're working on is a trauma study to understand how we give appropriate pharmacotherapy to people who survive trauma. And so we listened to one of the survivors' stories. Our study is about trying to figure out whether aspirin or low molecular weight heparin is better at preventing death and clinically important blood clots. Sounds like a board question, right? What's the answer? We don't know. But fortunately, we convinced Coy to give the lead investigator $12 million to answer that question. And so here's Jeff Wells, who, like Dawuan, is a survivor. And here's his story.
Short synopsis, diabetic infection, gangrene. Because my stroke was in the brainstem and I have some effects on the left and the right. Back to the hospital, coma. When I came home from the hospital, I didn't know what the future would be. Nobody knew what, you work all you can, but sometimes things get better, sometimes they don't. Waking up, laying in a bed, life is not what it was yesterday, and what is tomorrow going to be? And finding a way to remember or to move forward. And because I have been treated so well, and that's not necessarily the same for everybody, I realized that what I can do is to help where I can, where I am. It's just kind of a basic part-time. She needs somebody to be here to answer the phone. Good morning, law office. May I help you? That feeling of being powerless, of not being listened to, of just being a cog in a wheel, of being a number. That's not the world of medicine anymore. And this is helping drive it. Patients are listened to. And you're not fixing a disease in a book, you're healing a person.
Right. And so when you listen to patients like that, who survived a trauma only to go on and have a stroke, you realize how important it is to figure out which of two medicines, aspirin or low molecular weight heparin, is better post-trauma for preventing clinically significant blood clots, PE, stroke, and death. And I want to be involved in that kind of discovery, but I want to make sure that we do it in a patient-centered way. I want to make sure that we listen on what we should be measuring, how we should be measuring it, what works in your community in terms of how we can gather data from you. What is it that you want to know? How do we explain this? And how do we make sure that when we have the science to save lives and to improve quality of life, that we get that into the hands of patients who need that information. And one of the things that we're proud of, and I won't show this one, but there's a clip here. And we convinced the lead investigator that as part of their IRB consent process, that we heard from patients that nobody likes those IRB consent forms. And so we convinced them that we should be able to replace part of that with a video. And so we created a video that you could watch to decide whether you wanted to consent to be into the study. And there's the link, and I'm happy to share it with anyone. But the point was that we learned this by listening to patients about what was important to them. And that by doing that, we believe that patients begin to trust us. And we think that that's what really matters. Because if patients trusted that we were trying to help them be healthy, that if patients believed that research was answering questions that they had, that they found meaningful, and that could improve their longevity and quality of life. But what we've learned is that if we build that trust and maintain that trust, that we can do patient-centered discovery. I'm going to turn it back now to Dawuan to close us out.
If I could add the piece about the successful partnership that Dr. Mullins may not mention, I could mention is successful partnership when you talk about mutually beneficial at the end. I know from examples of being a part and seeing other community members and partners being a part of the selection of the director of research at the patients program, the School of Pharmacy, excuse me. And this level of engagement at every step demonstrate how a successful partnership should look. When you see that the community is a part, even at the high level of policy making, selection of the director, so they have their input value. So now the community and the stakeholders see the value that they add being involved at every single level of it. And we're leaving with a quote. It won't make sense to read it because we have it up there. But if we just take the moment to read it and understand, we will learn that there's a better way to actually engage and learn and research, going beyond just community. We actually talk about the patient at the center. We see the patient as a partner opposed to a subject at every step of the way. And I would leave it with the opportunity for discussions and questions.
Thank you.
Thank you so much, Daniel and Dawuan. We have time for a question or two. If anyone has a question in the audience that they'd like to ask our presenters.
Good morning, my name is Jing, and I'm a second-year pharmacy student. I just want to first thank you two for coming to the University of Mississippi. My question is, a big part of clinical trials, and probably a main problem with research when it comes to patient, is there's a very significant rate of them not being able to be followed through like the whole time. So have you found that when you do this in a patient-centered way that the dropout rate has decreased in your clinical trials?
So it's a good question. It's our hypothesis, and we only have our first clinical trial is a radiation trial that we're supporting out of University of Pennsylvania. It's in its third year. It is behind in recruitment, but much further along than any NCI trial of its kind has ever been. In addition to having survivors as advisors, we also have behavioral scientists and physicists from the National Cancer Institute who have participated in NCI studies. And every time we meet with them, they're impressed that this PCORI-funded trial is recruiting at a much faster rate than any other radiation trial has ever done in NCI's history. So that's an anecdote at this point, but we are collecting that data and we're pitting our trials against historical trials funded by other agencies, whether it's NIH, drug companies, whatever. And what we hope to be able to demonstrate is that by taking the time to listen up front, to design the study the right way, you will recruit faster, you will retain higher, and you will get more authentic data from patients. That is our hypothesis, and we hope to prove it. Come on, somebody's got to have another question.
I probably don't need a microphone. Could you just speak to the process of developing authentic relationships? It's a challenge. I mean, it may be an aspiration for many clinicians and for many researchers, but how do we go about that? What insights could you share about that?
So just to make sure they heard it, the question is, how do you develop these authentic relationships? And I'll have Dawuan start.
One thing that I would say is when you start to build that relationship, well, establish the relationship, when we come from a place of academia clinicians, we come in as the expert, the teacher. But sometimes that role needs to shift. Take the student role and understand, ask questions, help me understand from your vantage point. When you take that approach, that leaves some of the hard to reach population, patients, or partners, that gives them a feeling of empowerment, that it's not one-sided. I'm here to learn. You're not coming with a condescending tone or those that nature. And once you start with things like that, you're able to build authentic relationship, because now we have an equal playing field for some people, for them to really appreciate. And thinking about how this can be mutually beneficial on each side. Yeah, case in point, where we're talking about from the research side of things, we want to understand what contribute to breast cancer at a high prevalence rate in African American women. If the trial numbers are low, we want to reach that population, but within that community, we're accustomed to having medical mistrust in institutions, so they don't want to participate because research seems like a dirty word. So we reach the people with questions like, wouldn't you like to contribute to the outcomes that may prevent someone else from going through some of the experience that you have went through? More than likely, everyone would say, yes. Would you want to prevent your younger child or grandchild from experiencing some of these things and preventing? So a person would say yes. So having that level of understanding, and you see how it can be mutually beneficial. So come in and help me to better understand how can we develop a drug or alternative treatment that reach the people that are inside the clinical trial, so we don't have those data, those data points. So it's really important. So having the mutual respect, understanding, actually listening, and making sure it's mutually beneficial from both sides, and having transformational relationships, not transactional.
I mentioned that we have this 10-step framework that we published about 5 years ago. And what we've learned since in our current PCORI Methodology Award is the importance of a step that comes before step one, and that's pre-engagement. Right? We tend to think that we want to partner on our research project. And what we need to understand is that when you're partnering with the community, the first question is, what do you want, Marie, out of this relationship? Right? Because if we are already starting with, here's the study, how do you want to do it? They may not want to do that study. So the first thing is to talk about, what do you want out of this relationship? And so we learned from Pastor Lance that there were 5 conditions that were killing the people in his church, and that's what he wanted to learn about. Right? And so it's understanding what the other partner wants out of the relationship. We've decided to do this at the campus level, and so we have the support of the other deans, right? So we are a campus-wide infrastructure in addition to our partners. And so we believe that it's our job as the patients program to be there when your study ends. Because that's the helicopter research that University of Maryland wants to avoid, which is, we came, we got your data, we left, and you don't hear from us, and then a year later we come back because we want to get more data. That's so disrespectful in the lens of the community. And so we try to be in the community so that there's a presence there. And it's not about Dr. Smith's study or Dr. Jones' study, but it's about the University of Maryland really wanting to partner with this community, so that then when Dr. Smith or Dr. Jones wants to do a study, I can bring them to Bunsacourt, or I can bring them to Mount Lebanon, or I can bring them to Touchpoint at Mondawmin. And they can have a conversation there because the community is used to seeing the patients program there. And they understand that this is the University of Maryland, still here 5 years later, 10 years later. So I think that's the important part, is it's not about an individual study, it is about a relationship. And you've got to be there in between studies. And you've got to be there for events like National Night Out, or when Gail's godmother died. You've got to be there for what's important to them if you want them to be there for what's important to you.
And last point that I would add to that is avoid using the Masonic complex, like your Messiah, Avoid using the Messiah complex, thinking that you're here to save me. Patients don't want you to save them, they want you to help them save themselves. So when you come with that mentality, you immediately shut off the patient with that. So if you come with a more empowering approach, that, hey, I'm here to help you help yourself, and we are helping each other, and end of this is something that's really important. Help me save myself. Don't come in with the, I'm here to save you complex and language. Thank you.
Considerable amount of food for thought. That was outstanding, and I moved by your story, Dawuan. I'm touched by the things that you guys are doing in Baltimore, and I realize that we have a lot of work to do here in the state of Mississippi as well. So thank you for sharing your stories and your experiences with us. And Dawuan, we'd like to share something with you as well, for sharing your perspective with us, and also to recognize you for the work that you're doing in your community and beyond to improve people's lives. We just want to present you with a small token of our appreciation.
Thank you.
And Daniel, we would like to present you with the Coy W. Waller Distinguished Lectureship Award in recognition for your outstanding contributions to pharmacy administration as a researcher, as a role model, as a mentor, and an educator, and as well as your dedication to patients through your research and your actions. And we want to thank you all again one more time for joining us to honor the legacy of Dr. Waller, and we are done for the day. Thank you all very much for attending.